So, going into the history, the first patient received radioiodine in 1941, and Dr. Saul Hertz and Dr. Arthur Roberts were responsible for it. And to tell a story, the year was 1936, and it was an August gathering like this, and the institution was not Shankara, it was Harvard Medical School, and the speaker was Dr. Compton. He was the then president of Massachusetts Institute of Technology. And the topic he was talking about was how physics could be used for the benefit of biology and medicine. And like attending the session was Dr. Saul Hertz, and he raised his hand and asked a simple question: Can iodine be made artificially radioactive? No Google, no easy access to sessions, references. So this Dr. Compton went back and wrote a letter to him 1 month later. Yes, 2 lines. Yes, it could be made artificially radioactive, and the second line was it emits beta and gamma. To which a week later, he told, okay, it could be used for treating thyroid diseases. And within 2 years, a cyclotron was installed in MIT, and in 1941, exactly 5 years later, the first patient was given radioiodine successfully to treat Graves' disease. So, in our clinical practice, we use radioiodine for diagnostic purposes, and in therapeutic domain, it is used for thyroid cancer and for hyperthyroidism. Diagnostic purpose, it could be uptake scans, it could be whole body scans. The dose we use is really less, in the range of microcuries to hardly 1 to 2 millicurie, which doesn't have really any clinical effect. To say the side effects doesn't appear in these ranges. And in hyperthyroidism, the uptake scan shows Graves. Hyperthyroidism could be treated, could be ablated completely with a lower dose of radioiodine, possibly 10 to 15 millicuries. And thyroid cancer, differentiated thyroid cancer, you all know, it has been well established and in guidelines. So post 1941, the number of thyroid cases started with the development of better diagnostic modalities. More thyroid cases started detecting, thyroid cancers started getting detected, and people started getting aggressive in using radioiodine, and more use, more side effects. And from 1973 to 2002, the complication it has gone 2.4 folds, and most of the cases has been attributed to, as I said, the uncontrolled or those periods when the guidelines were not so strict. It was used more often in an empirical way. So this is iodine 131. The half-life is 8 days, physical, and when it's given to the patient, the biological action comes into play, and within 5 days there is the effective half-life. And 89.9% is the 606 keV beta particles. That is the high energy which actually provides the effect and the side effects, which causes the cell killing, is the beta rays. And lower down you can see, going into the stable xenon, 81.82%, 364 keV gamma. That is the one which helps us in imaging using gamma cameras. The maximum calculated range of beta particle is 3.45 millimeter. Hence, the effects and luckily the side effects are focused only on the organs of accumulation and retention. At this point, I could safely say that in the era of targeted or precision medicine, this could be considered as an ideal drug. Albeit the complications, which I am going to say in upcoming slides, this is sort of an ideal one. So the complications could be acute or chronic, and less than 3 months generally considered as acute side effects, and gastrointestinal, salivary, neck, hematopoietic and pulmonary effects are commonly seen and recorded. more than 3 months, salivary, eye, pulmonary effects, gonads, bone marrow, and second primary malignancies. Salivary dysfunction is which is commonly seen in almost all patients receiving high doses in multiple sessions. It is mostly reported by the patient during the follow-up sessions and could be due to the direct result of radiation injury, acute radiation salivaritis, which could later become chronic due to duct obstruction. So, a few articles say assess the dose required for creating complete salivary damage, but still even lower doses in the range of a single dose of 100 or 150 millicurie can cause salivary damage. It's seen 30% in adults and luckily lesser common in children. Salivary glands, they have sodium iodide importer concentration much higher compared to other normal tissues, other tissues, and it concentrates radioiodine along with the remnant or other differentiated thyroid areas. And the onset of the effect could be anywhere between 2 days to 6 months after the dose, represented by pain, swelling, mostly in the parotid, much more than in submandibular. And in later stages, xerostomia, which would be very detrimental for the patients and would have made patients differ from further treatment. It's mostly dose related and the number of doses increases in the case of metastatic diseases. The chances of xerostomia or salivaritis and xerostomia increases. So the reported incidence has been very varying, 12% to 67% in various studies. And the ways to tackle has been much of a confusing way, and hydration is the most commonly recommended method. Sour candies, which secrete xylogogues to increase the salivary secretion and to get the absorbed thyroid out of the salivary gland. Amifostine, which is a non-radioprotector, and other cholinergic agents are suggested but not recommended by any guidelines. Sour candies, the timing, this is commonly used in almost all the nuclear medicine centers, might be including the center we have here. And either sour candies or lemon juices are used. One might be institution-wise protocol could be there. ATA doesn't, they easily wash hand, and they told the evidence is too low to make any recommendation. So to consider, a few studies have seen that any sour candies which causes the salivary secretion given within 1 hour of iodine dose could lead to much worse salivaritis. And the preferred method is in after 1 hour of radioiodine, giving radioiodine, and repeated 3 to 4 hours for 2 to 3 days. Stomatitis is commonly seen 5 to 7 days after therapy, and it is due to the direct effect of radiation, which could be managed by normal mouth washes, and encouraging the patient to do it often. The change in taste has also been recorded, and this is due to the secretion directly into the mouth and radiation destruction of the lingual salivary gland taste buds. And it also has been associated, and most of the patient gives a feeling of metallic taste. And usually self-resolving, no need for any other medications, and in 2 or 3 months, mostly the taste gets back to normal. Since it is orally taken, gastrointestinal complications are high. The most concentration is seen in the stomach area at the time of administration, and nausea is commonly seen but is rarely accompanied by emesis. And anti-nausea medications could be they are enough to handle the situation, and if vomited, the situation changes. The patient just after taking a high dose, possibly a 150 200 millicurie, vomits. in an area. If it is inside the hospital, we could manage. If it is a public, it becomes a public hazard, which need to be managed with much difficulty because of the exposure to the public. So we normally recommend pre-medication with normal ondansetron, which is doing its work, and normally patients don't go for vomiting after the administration. If given less than 200 millicurie and the exposure to the blood is 2 gray or 200 centigray, the other effects of acute radiation sickness doesn't actually come into play. In a case of extensive neck nodal mets or large lesion or big residual is left over and a high dose is given, radiation thyroiditis could be seen. But in this time, most of the times the surgery is being done in specialized cancer centers with high volume thyroid surgeons. This incidence is very low, and I have not seen in my hospital till now any neck pain or swelling possible which could be attributed to the radioiodine. Nasolacrimal deck, just like in the other salivary, they also have sodium iodine importers, and the taken in radioiodine causes stricture or obstruction of the duct and resulting epiphora. The ATA has already recognized this, and the guidelines say that surgical management, dilatation, stenting, or if needed, surgical management can be done if further treatment is needed or the patient is symptomatic. Gonadal radiation and fertility related issues are the one thing which has come up little bit confusing, because radiation, chemotherapy related infertility or fertility related issues are well known to public, and since the radiation is introduced into the body, they definitely are worried about the effect of fertility, and the more the number of younger patients, the scene is little bit bad. Radiation from free and iodinated proteins circulating in the blood and urinary excretion of radioactive iodine. In acute, immediately after giving, the way of elimination is renal, and urinary bladder has a high concentration, and in prostate and uterus can have, ovaries can have exposure to high radiation. And as I told before, good hydration has been the cornerstone in radioiodine therapy, and with good hydration and frequent micturition, this exposure can be limited. Male infertility immediately after giving radioiodine, if followed up for a while, elevated FSH and reduced testosterone can be recorded, but doesn't translate to permanent infertility, and much of the patient or the studies which have been done doesn't recommend doing sperm preservation in males, but they suggested if more than 400 millicurie is being given to the patient in multiple sessions, they suggest that patient it could be considered. For female infertility, transient amenorrhea and oligomenorrhea is recorded, but no differences were seen in stillborns, preterm births, low birth weight, congenital malformations, or death during the first year of life. And early menopause, even though theoretically possible, but has not been proven by studies. 50 and 49.4 were the patients who have received radioactive drugs and not received radioactive, the age of menopause, and not statistically significant also. Considering the infertility, ATA 2015 recommend those receiving more than 400 millicurie should be counseled for potential risk of infertility. Sperm banking may be considered, and they also recommend to wait for 3 months minimum if the male receives iodine therapy before it's the time duration for one full sperm cycle to avoid potential for transient chromosomal abnormalities. Women of childbearing age receiving iodine 131 should have a negative screening evaluation, which is the most basic thing needed for any nuclear medicine procedure. They should not be pregnant, and they should defer pregnancy 6 months to 1 year after the radioiodine therapy. If they were pregnant and iodine 131 was given, if it is too early in the pregnancy before implantation, that's very unlikely to have much effect on the embryo. But the situation changes if it is from 2 weeks organogenesis time to 10 weeks thyrogenesis time. The possibility of introduction fetal thyroid ablation and birth defects and growth retardation with low IQ were recorded if this is the duration of introduction of radioiodine within 2 weeks to 10 weeks. Breastfeeding need to be stopped for 2 reasons. One is they have in those periods of breastfeeding high sodium iodine symporter in the breast tissue, which concentrates iodine. So radioiodine will be introduced into the breastfeeding child and possibly ablating the child's thyroid. And also to limit the radiation to the breast tissue, the chances of second primary malignancy is the concern over there, but very less likely to be. So the idea is to discontinue breastfeeding for at least 6 to 8 weeks before radioiodine administration. If need to be given in an urgent basis in case of skeletal metastasis or distant mets, dopaminergic agents like abergoline can be given, which would suppress the breast milk secretion. Bone marrow suppression, it is not normally a permanent bone marrow suppressed situation has not been experienced by Nikhil in all these years. There have been variations in count. WBC count used to come down but temporary, used to come up before the next session if there is no extensive skeletal metastasis. Patient who has extensive skeletal metastasis and the disease is differentiated, accumulates high intense radiation and exposure of marrow to more than 2 gray. If it happens, it is the limiting factor for discontinuing therapy. So in all cases, a baseline count should be done, and renal function is to be done prior to introducing radioiodine each cycle. The pulmonary fibrosis, in case of bilateral pulmonary nodules, metastatic nodules accumulating radioiodine, this radiation pneumonitis and pulmonary fibrosis is seen, and pulmonary function test needs to be done prior to each cycle to look for a deteriorating function. This is much important because commonly seen if it is in pediatric patient, and more the time for development of treatment related side effects in pediatrics. Second primary malignancies commonly seen both solid and leukemia. Unlike previously thought, the incidence is little bit high. The conventionally thought upper limit for therapy was 600 millicurie, which is also recommended by ATA. But there is no actual upper limit, and in clinical practice, we all give doses much higher than that, individualizing the treatment plan and response of the patient to the treatment, response of the disease to the treatment. So this is a study published in JCO, which studied 1,48,215 patients, DTC, treated with RAI, and adult patients. They found incidence of development of AML and CML alone, and no solid tumors in adult patients. The pediatric patients also published in JCO 2 years back, 51% and 23%, 51% for hematological malignancies and 23% for solid malignancies. So the graphs from the respective studies both shows that solid malignancies and hematological malignancies, the cumulative incidence is high compared to those who have not received radioiodine therapy. So even though generally considered as safe and given to almost all patients other than low risk, in almost all centers, there are complications. The recent studies are telling that the complications are a little bit higher than which have been already thought about. And considering multiple factors rather than the risk stratification alone, the age of the patient, the longevity of the patient, the performance status, other comorbidities, the time available for the patient to develop such side effects, and also other factors like smoking, alcoholism, which could attribute to other malignancies, which could come into play in this, also need to be taken into account before deciding on radioiodine therapy. And just to conclude, these are the less common adverse effects of high-dose iodine treatment: hypocalcemia, brain edema, cord compression, impaired liver and kidney function, cystitis. All these are hypocalcemia. In Graves patients who are given radioiodine ablation, hypocalcemia has been recorded. Few case studies are there. And in case of brain edema, wherever generally in thyroid metastasis, wherever possible, we will hand over to the surgeons. You resect as much as possible and give us back for therapy. Same the case with brain. If possible, do a surgery, stereotactic radiosurgery or resection, and after that radioiodine is found to be effective, but the edema which could be controlled by corticosteroids, and same is the case with cord compression, vertebral metastasis, we recommend RT prior to giving radioiodine if there is impending cord compression. And as told before, the liver and kidney are the modes of excretion, and cystitis, since bladder, we have seen a few cases of cystitis and few recorded articles are there. And I thank you for kindly listening to me in this late afternoon hours. Thank you.
Thank you, Nikhil. So any clarifications?
Those toxic
points
doses you were
make?
saying, they were cumulative doses or single one-time dose?
600 millicurie. 600 millicurie is cumulative.
And 400?
That's also
All
cumulative.
cumulative.
Because even if the highest dose we give for skeletal metastasis, 200 millicurie, doses beyond 200 millicuries have also been studied. RCTs have shown that doses beyond 250 millicurie doesn't produce much more cell killing than 200 millicurie, and no response.
But many patients are likely to go ahead and receive more than 4 to 600. So they'll end with permanent salivary damage.
If the management for salivary damage, to prevent salivary damage, is not, strict guidelines are not there. So we try all these parotid massaging, candies and all, each cycle. And if not properly done, I have got few patients, 3 or 4 patients, xerostomia. In 1,500 patients I have given high dose therapy, not ablation, high dose therapy, metastatic diseases. And the incidence has been very low, and multiple sessions have been given, but still it is recorded, incidence is there. Possibility needs to be considered.
Yeah. You said above 600 there is absolute salivary dysfunction.
It's not always.
Okay.
The article says
Yeah.
it could be, but I have given
Correct.
more than one curie
Yeah.
without.
Because we've seen patients receive more and they do
Yeah.
not specifically complain about.
In the acute, because we called them back, like in the first 3 months, they would be saying all this, which is resolving on its own.
Thank you, Nikhil. Please step forward for your felicitation.